Good afternoon. Thank you, Professor El-Bashlawi and the scientific committee for inviting me. Today, I will discuss the novel agents targeting ineffective erythropoiesis and iron dysregulation in thalassemia. These are my conflict of interest disclosures. The objective of today's talk is to explore novel therapeutic targets based on advances in our understanding of ineffective erythropoiesis. To recap, majority of the complications of thalassemia stems from ineffective erythropoiesis and also iron dysregulation. I shall briefly summarize the pathophysiology of ineffective erythropoiesis in thalassemia, given that Professor Musallam has already tackled the mechanisms in detail. In the developing red cell of a thalassemic patient, imbalance in the synthesis between alpha and beta chains result in relative excess of the unpaired globin chains. These unpaired globin chains go on to form unstable tetramers, which precipitates into inclusion bodies. In some instances, mutations result in unstable globin chain variants. This leads to generation of hemichromes and reactive oxygen species, damaging the red cell. Signaling through GDF and SMAD2/3 pathway also leads to increased apoptosis, decreased red blood cell differentiation, and maturation. In beta thalassemia, HSP70 translocates out of the nucleus in an attempt to refold the alpha globin aggregates, facilitated by XPO1, thus leaving GATA1 unprotected. Caspase-3 takes advantage of HSP's absence and degrades GATA1, leading to reduced differentiation and maturation arrest. While the exact pathophysiology of alpha thalassemia is less understood, it is thought to work through a similar manner. So how does iron contribute to an ineffective erythropoiesis? The influence actually goes both ways. Increased iron recycling and absorption lead to increase in erythroid iron intake, and this in turn leads to increased hemichrome generation and reactive oxygen species generation. This leads to increased erythroid cell replication and decreased differentiation, which is the hallmark of ineffective erythropoiesis, with hypoxia inducing HIF2 alpha, which induces more erythropoietin generation, leading to increased progenitor erythroid cells. This in turn will increase the expression of ERFE, or erythroferrone, which then will suppress hepcidin. The inhibition of hepcidin leads to further iron absorption and recycling, and thus leading to increased erythroid iron intake, and round and round it goes. What's more is that transfusion, because of the increased iron intake from the exogenous blood, will further exacerbate the ineffective erythropoiesis and the iron overload. Our advances in the understanding of mechanisms of ineffective erythropoiesis has provided us with a multitude of potential therapeutic targets. I will not be addressing luspatercept since it has been extensively discussed by other speakers, and hydroxyurea is already well known to the audience. Today, I shall discuss the therapies in order of further progress in development to the least developed. Let us start with mitapivat. Mitapivat is a pyruvate kinase activator and is hypothesized to enhance glycolysis and increase ATP, and thus reduce hemichrome reactive oxygen species, reduce oxidative damage, leading to a reduction in hemolysis in infective erythropoiesis, thus improving anemia, and perhaps it can also reduce dysregulated iron metabolism and therefore reduce the iron overload. Preclinical data comes from chronically transfused beta thalassemia mice, where mitapivat lengthened the transfusion interval from 11 days to 14 days and reduced the liver iron concentration. In the phase 2 study of non-transfusion dependent alpha or beta thalassemic patients, patients were started at 50 milligrams twice a day of mitapivat for 6 weeks, followed by dose escalation to 100 milligrams twice a day for 18 weeks, and then to long-term extension study. Hemoglobin increase of at least 1 gram per deciliter between weeks 4 to 12 were achieved in 80% or 16 out of 20 patients. All 5 out of 5 alpha thalassemic patients and 11 out of 15 beta thalassemic patients achieved this primary endpoint. Sustained development and improvements in the markers of hemolysis and erythropoiesis can also be seen. Common adverse events include initial insomnia and headache. As you can see on the right-hand panel here, the bone densities were stable up to 72 weeks. 2 phase 3 randomized controlled trials, ENERGIZE and ENERGIZE-T, will evaluate mitapivat in transfusion-dependent thalassemias and non-transfusion-dependent thalassemias. Next, we'll talk about thalidomide. Thalidomide is thought to increase fetal globin expression through a reduction in BCL11A and other fetal globin repressors. There has been a number of single-arm studies in the use of thalidomide in both transfusion-dependent as well as non-transfusion-dependent thalassemia patients. In this meta-analysis shown on the right-hand panel, of the 11 single-arm trials and 1 two-arm trial, totaling 451 participants, it was shown that 83% of the transfusion-dependent thalassemic patients had a 50% or greater reduction in transfusion. 91% of the non-transfusion-dependent thalassemic patients also had an increase in hemoglobin of at least 1 gram per deciliter. However, the p-value did not reach significance. Common side effects include constipation, somnolence, high ALT, as well as rash. Rare adverse events include peripheral neurotoxicity, headache, central venous thrombosis, and seizures. Next, we'll move on to phase 2 trials that are in progress. First is etavopivat, also called FT4202. It is also a pyruvate kinase R activator and shares the same mechanism of action as mitapivat, although it does not inhibit aromatase. In a phase 2 open-label study of 60 adult patients with non-transfusion dependent and transfusion-dependent thalassemias, as well as sickle cell disease on transfusion, patients will be placed on etavopivat 400 milligrams daily for 48 weeks. Notably, this study also includes both alpha and beta thalassemic patients. The primary outcome for the transfusion-dependent thalassemic cohort is at least a 20% reduction in red blood cell transfusions over a continuous 12-week period. For the non-transfusion-dependent thalassemic cohort, it is an hemoglobin increase of at least 1 gram per deciliter at week 12. In terms of secondary outcomes, for the transfusion-dependent thalassemic cohort, it is at least a 1/3 reduction in red blood cell transfusions. And for the non-transfusion-dependent thalassemic cohort, it is a hemoglobin increase of at least 1 gram per deciliter at week 24 and 48. The estimated completion date for this study is March 2025. Next, we'll move on to ISIS 702843, also known as the TMPRSS6 antisense nucleotide. TMPRSS6 LRX is an antisense nucleotide to matriptase 2, encoded by the TMPRSS6 gene. Inhibition of the matriptase 2 increases hepcidin and reduces ineffective erythropoiesis. In the phase 1 healthy volunteer study, it was shown to reduce serum iron transferrin saturation and increase plasma hepcidin. However, small reductions in hemoglobin of 9 grams per liter and reduction in reticulocyte hemoglobin of 13% at 40 milligram dose were observed. It is currently in a phase 2A randomized open label trial, and the estimated target recruitment is 36 non-transfusion dependent beta thalassemia adults. Notable inclusion criteria includes a liver iron concentration between 3 and 20 milligram per gram dry weight. And if the patient is on chelation, they must have at least 5 milligram per gram dry weight of iron. Notable inclusion exclusion criteria include alpha globin triplication and the patients being on hydroxyurea. The dosing of the 10/6 LRX is 30, 50, or 80 microgram subcutaneously every 4 weeks. Primary outcome is a hemoglobin increase of at least 1 gram per deciliter at week 27. And secondary outcomes include a hemoglobin increase of at least 1.5 grams per deciliter, a liver iron concentration decrease of at least 1 milligram per gram dry weight at week 53. The estimated completion date is October 2023. Continuing on the trend of the hepcidin ferroportin axis, we now have SLN124. SLN124 is a GalNAc conjugated 19-mer double-stranded siRNA. It increases hepcidin by inhibiting TMPRSS6. In the Gemini 2 trial, which is a phase 1 randomized double-blind placebo-controlled single ascending dose study evaluating 1 milligram per kilogram, 3 milligram per kilogram, and 4.5 milligram per kilogram subcutaneous SLN124. Plasma hepcidin levels increased in a dose-dependent and time-dependent fashion, as can be seen on the right-hand side here. Serum iron and transferrin saturation were also reduced at a dose-dependent and a time-dependent fashion. No severe adverse events or treatment-emergent adverse events leading to withdrawal were observed. The study continues to recruit. Next, we move on to apotransferrin. As is shown on the right-hand diagram here, apotransferrin inhibits TFR1 expression and decreases TFR1 partitioning to reticulocytes during enucleation, and thus enhancing nucleation of defective beta thalassemic erythroid precursors. The decreased TFR1 upregulates hepcidin in a iron and earthy independent fashion, thus reducing ineffective erythropoiesis. In a phase 2 open label trial of 12 non-transfusion dependent beta thalassemic adults, human apotransferrin given intravenously every 2 weeks for 14 to 18 weeks. The primary outcome includes a change in hemoglobin and changes in the number of red blood cell units transfused per week. Secondary outcomes include iron parameters, reticulocyte counts, erythropoietin levels, as well as PK/PD parameters. The estimated completion date is March 2021. Again, continuing on the same line is PTG300. It is a hepcidin mimetic. In the phase 2 single-arm open-label study of 63 transfusion-dependent and non-transfusion dependent beta thalassemia patients aged 12 or greater, PTG300 were administered at 3, 10, 20, 40, 80 milligrams weekly, up to 40 milligrams twice weekly subcutaneously. The results of the 35 transfusion-dependent beta thalassemia subjects were reported in 2020. And on the right-hand panel here, we can see the patients where their transferrin saturations were reduced with dosing, but the transferrin saturation and iron increased during pre-dose, which is as expected. Further dosing with the PTG 300 also led to further reduction in transferrin saturation and iron. In terms of treatment-emergent adverse events, transient injection site erythema occurred in 5 out of 35 patients. Whether the reduction in transferrin saturation and iron translates into improvement in ineffective erythropoiesis is currently unknown. Next, we move on to vemifeport, again, along the hepcidin-ferroportin axis. Vemifeport is a ferroportin inhibitor. The inhibition of ferroportin is hypothesized to improve ineffective erythropoiesis via a dampening of the TFR2 scribble pathway and suppression of the mTORC1 signaling of activated EPO receptors. In 2 ongoing phase 2 studies aimed at non-transfusion dependent and transfusion dependent beta thalassemia adults are currently ongoing. Here on the left and right are the details of the 2 trials. On the left here, we have the phase 2A study for non-transfusion dependent beta thalassemia adults, where the target recruitment is 25 patients. Notable inclusion criteria includes adolescents and adults, at least ages 12 to 65, and a hemoglobin less than 11 grams per deciliter. Notable exclusion criteria includes iron chelation therapy, transferrin saturation less than 30%, a liver iron concentration of greater than 15 milligram per gram dry weight, and a cardiac MRI T2 star of less than 20 milliseconds in B12 deficiency. Patients will be randomized to 60 or 120 milligrams daily versus BID of the vemifeport versus placebo over 12 weeks. Primary outcome includes looking at changes in hemoglobin, systolic blood pressure, heart rate, ECG parameters over 12 weeks, as well as safety parameters. Secondary outcomes include change in serum iron, ferritin, transferrin saturation over 12 weeks, as well as PK/PD parameters. The estimated completion date is November 2021. For the phase 2B trial in transfusion-dependent beta thalassemia adults, the estimated recruitment is 80 patients. Notable exclusion criteria includes partial or total splenectomy, cardiac iron overload history, significant lung disease, and greater than grade 1 uncontrolled hypertension. Patients are again randomized to the same regimen as the non-transfusion dependent study, but it also includes a 12 weeks post-treatment follow-up period. The primary outcome here is more than 33% and 2 or greater than 2 units reduction of red blood cell transfusions at weeks 13 to 24. Secondary outcomes include transfusion reduction and quality of life. Estimation completion date is July 2023. Next, we move on to rapamycin or sirolimus. In this pathway, the absence of FOXO3 induces activation of the JAK, AKT, and mTOR pathway, which promotes ineffective erythropoiesis. mTOR inhibition by drugs such as rapamycin in the FOXO3 null mice, as well as in the Th3 positive thalassemic mice, improve red blood cell and hemoglobin production. Based on this finding, the Thalarap trial is a phase 2 open label study of 45 transfusion-dependent beta thalassemia adults. Sirolimus 0.5 milligram daily for 1 year are given to the patients, and the primary outcome is change in fetal hemoglobin at day 360. Secondary outcomes include change in hemoglobin at day 90, 160, changes in gamma globin expression at days 90, 180, 360. Hemolytic, erythropoietic, iron biomarkers are also measured, as well as transfusion status and quality of life. Estimated completion date is April 2022. Last but not least, we'll now move on to phase 1 trials. Benserazide is a drug that is already approved, but it is in the use of Parkinson's disease. It is used in combination with L-DOPA, where it increases the half-life of L-DOPA. One of its salutary effects is increase in fetal hemoglobin expression through derepression of the fetal globin regulators. In the beta-yak mice model, it was shown to increase F cells. And on the right-hand panel here, you can see that in the anemic baboon model, it induced gamma globin mRNA up to a 13-fold increase. Therefore, a phase 1b dose escalating study was embarked with a target recruitment of 36 patients with non-transfusion dependent beta thalassemics. Cohorts 1 to 3 includes benserazide at 1, 3, and 5 milligram per kilogram Monday, Wednesday, Friday per week. And the fourth cohort will consist of the optimized dose from cohorts 1 to 3. Primary outcome includes safety, tolerability, as well as PK/PD parameters. Secondary outcomes include changes in fetal hemoglobin, F cells, hemoglobin F per cell, LDH, hemoglobin, and soluble transferrin receptor level. Estimated completion date is August of 2022. While the previous therapies are currently ongoing in their development, there has been a few that has already been discontinued. First is IMR 687. It is a phosphodiesterase 9 inhibitor, which is hypothesized to increase intracellular cyclic GMP and increases fetal globin expression through an undetermined mechanism. In a thalassemic mice model of 18 mice treated with IMR 687 at 30 or 60 milligram per kilogram per day for 30 days, there was a dose-dependent increase in hemoglobin, red blood cell, as well as reduction in reticulocyte count. As you can see here over figure 1 on the right-hand panel here, at 60 milligram per kilogram dose, there was a 1.5 gram deciliter increase in hemoglobin compared to the untreated mice. As well, as you can see in figure 2 here, the mature erythroblast populations increased while the immature erythroblast populations were reduced. Based on these findings, the phase 2b randomized controlled trial was embarked, consisting of transfusion-dependent and non-transfusion-dependent beta thalassaemic adults. In terms of adverse events, it was mostly nausea and headache. Unfortunately, no benefits in transfusion burden were seen compared to placebo. Furthermore, there was no improvements observed in most disease-related biomarkers, including hemoglobin, and therefore the study has been terminated. Next, we move on to LJPC401. This is a synthetic hepcidin, and in the phase 2 open label study of 84 transfusion-dependent thalassemic patients ages 14 and over with cardiac iron overload, patients were randomized to either delayed or immediate therapy, delayed being the first 26 weeks being on standard of care, and the next 26 weeks being on LJPC401, 20 milligrams subcutaneously weekly. Or in the immediate therapy is where patients are put on LJPC401, 20 milligrams sub-Q every week for 52 weeks. The primary outcome is changes in T2 star value on cardiac MRI. Secondary outcomes include changes in T2 star liver MRI, changes in serum iron, hemoglobin, transfusion volume. There were no significant differences in either primary or key secondary outcomes, and therefore the study was terminated. Next is Roxolitanip. In the phase 2a single-arm open-label study of transfusion-dependent thalassemic participants, Patients were placed on Roxolitanip 10 milligrams twice a day for 30 weeks. The primary endpoint, we're looking at differences in transfusion requirements at week 6 and 30 versus the 24 weeks prior to drug dosing. Secondary outcomes include changes in spleen wall volumes at weeks 12 and 30, changes in spleen length, as well as changes in pre-transfusion hemoglobin. What is observed was that there was a reduction of 5.9% in the transfusion requirement of these patients. Although 24 out of 25 had some degree of spleen volume reduction at week 20, because the major purpose of reducing spleen size in the patients with TDT is to improve pre-transfusion hemoglobin, and the related reduction in transfusion needs where Roxolitanip has been shown to have limited effect, no further development were planned as a result of the mixed results. So if one drug worked well, what about the combination therapy? In this proof of concept experiment, Guerra et al. Took beta thalassemia mice, and they were treated with either singly of RAPGLL, which is an analog of luspatercept, or with the TMPRSS6 antisense oligonucleotide, or the combinations of. And it was found that the luspatercept analog plus the TMPRSS6 antisense nucleotide achieved the highest increase in both changes in red cells as well as other parameters compared to either agent used singly. TMPRSS6 antisense oligonucleotide and the luspatercept analog with the TMPRSS6 antisense nucleotide treated mice also showed a reduction in reactive oxygen species, splenomegaly, iron, transferrin saturation, as well as an increase in hepcidin levels. And it's only the combination that was shown to have reduced erythropoietin as well as increased erythropoietin. The variable success of these novel therapy in the diverse clinical presentations of thalassemia shows us that there are still gaps in our understanding of ineffective erythropoiesis and hemolysis in thalassemia. Therefore, there may be additional genetic modifiers that have yet been discovered. And as a result, the Inherent is a multinational collaboration aimed at searching for genetic modifiers in hemoglobinopathies through large-scale multi-ethnic GWAS. It is composed of 9 existing international regional consortia with 160 experts from 89 organizations and 36 countries. It consists of 5 working groups: clinical, genotyping, data management and analysis, ethics, and knowledge translation. Participation in the Inherent network is open to any group that can submit 30 samples with the core phenotypic description, and the target recruitment size is 30,000. Please contact me or Petros Kontouris if you're interested in contributing. In conclusion, advances in our understanding of ineffective erythropoiesis and thalassemia has enabled the development of novel therapeutic targets. Consideration should be given to combination therapies. Gaps remain in our understanding of the pathophysiology of thalassemia, and in particular, alpha thalassemia. The discovery of genetic modifiers of hemoglobinopathies through an international multi-ethnic GWAS may yield more fruitful therapeutic targets, perhaps construction of polygenic risk scores for our patients for prognostication purposes, as well as individualized treatment approach. And with this, I draw my talk to a close. Thank you very much for your attention.